Welcome everyone to this month's webinar from the National Center for Integrated Behavioral Health in Primary Care. This month, we'll be talking about using open notes to promote engagement and equity in integrated behavioral health. And we'll be hosting two excellent speakers. In the next slide, we'll talk about the NCIBH. All right, so the NCIBH is a center that's funded by HRSA. The mission of the NCIBH is to prepare clinicians with the expertise and leadership for integrated behavioral health in primary care. We have three core objectives. One is enable implementation of IBH training and practice models in primary care. And second is identify and disseminate best practices of scalable IBH training in primary care. And the third is catalyze co-learning about research and training through a community of practice. You can connect with us in a number of ways to join our activities and approaches to disseminate integrated behavioral health in primary care. I want to thank many of our partners, including AFP, WMC, CFHA, who have worked with us over the years to advance this work. Join our community of practice. We have monthly newsletters. We have health equity initiatives, and please follow us on Twitter at NCIBH2, and also contribute to our IBH collection that is currently live on Meta portal through the WMC portal. We have more webinars that we've done in the past and more to come. You see here one we did with Wellbeing Trust. Please take a look at it because it's worth seeing. Next, please. Next, I'd like to introduce speakers. We have two well-known speakers in this area. One is, the first I want to introduce is Dr. Sandy Blount, Alexander Blount. Dr. Blount is a professor emeritus of family medicine at the University of Massachusetts Medical School, where he founded the Center for Integrated Primary Care. His program has trained numerous clinicians in this area, over 4,000 around the country, around the world. He's written many books, including Integrated Primary Care, The Future of Medical and Mental Health Collaboration, Patient-Centered Primary Care, and is also a past editor of Family Systems and Health, the Journal of Collaborative Healthcare. He's a past president of CFHA, or Collaborative Family Healthcare Association, and is currently the co-chair of the National Integration Advisory Council, part of the HRQ Integration Academy. He currently provides training and consultation in integrated behavioral health in primary care, patient-centered care, and team-based telemedicine. Thank you, Dr. Blount. Next, I want to introduce Dr. Neil Corson, a dear friend of mine. Neil is a physician scientist at the Center for Outcomes Research and Evaluation at the Maine Medical Center. He is co-lead for Rural Health Research and Delivery Core for the Northern New England Clinical and Translational Research Network. In this role, he is responsible for building bi-directional relationship within Maine Medical Center and several rural health hospitals to stimulate research. It is in this context that his leading work on community-engaged research. Importantly, Dr. Corson is also a member of the National Integration Advisory Council, where Dr. Blount is a co-chair. I'm pleased to introduce to you both Dr. Blount and Dr. Corson.
Good morning. It's an honor to be here. We want to talk about taking a requirement that is current, the requirement that patients be given access to reading, easy access to reading the notes and other text in their medical record, and talk about how it can be made part of enhanced patient-centered care and how it can be a step toward equity in healthcare. Let's start out with a framing perspective here, and that is that good healthcare is a necessary part of any step towards social justice. We remind ourselves that chronic illness rates, rates of behavioral morbidity and medical morbidity, quality of life ratings, birth outcomes, life expectancy, in other words, the important outcomes of healthcare all correlate with income. That low income and low education on one hand, and race and ethnicity on the other hand, interact in reciprocal ways. That if you are low income, you will have worse outcomes. If you are a member of a minority group, statistically, you will have worse health outcomes. And if you are a member of a minority group, statistically, you will have likely to have lower income. In other words, social justice demands that we go beyond equality of access to equity in care. It makes sense that the people with the greatest burdens of health would receive our most robust efforts on their behalf. Behavioral health is crucial to a population approach to health in general. And behavioral health in primary care is how you make a population approach to health. It turns out that that the majority of people, if offered a referral by their PCP to a mental health facility or substance use facility, will not go. The internal stigma is too strong, no matter what the external stigma situation might be. And so for those folks, the only way to offer them behavioral health help and therefore to impact their health outcomes generally is to offer it in primary care. So moving behavioral health services into primary care is the single most effective approach at reducing stigma in relation to access and offering equity in healthcare. A reminder that of the way Surgeon General Satcher put it, which was that racial and ethnic minorities are less inclined than white people to seek treatment from mental health specialists. Instead, studies indicate the minorities turn often to primary care. This is where our efforts need to be to reach the folks that most need behavioral health services of our patients. Dr. Corson.
Thanks, Sandy, and good morning, everybody. It's an honor for me also to be able to talk to you and to present with my friend Sandy, who I've learned a lot from in the past, and I've been learning from as we've been putting all this presentation together. Just a little more background, because I realized it wasn't in my bio. I'm a family doctor by background. I practiced for almost 20 years in rural Maine before having a midlife career switch, and have worked on behavioral health integration with primary care practices in Maine for close to 20 years now. What I want to talk about now, the point I want to make in the next few slides, is the idea of sharing what's in our notes, of sharing the health information in our records with our patients, is one that we've been talking about for a long time. The Institute of Medicine, now called the National Academy of Medicine, released the Crossing the Quality Chasm report 20 years ago this year, and among the rules that were recommended to address the quality challenges in the healthcare system that were identified in that report was a number of recommendations that lead to the recognition that patients are in control of their healthcare. This was a change in thinking at the time, that we had a much more paternalistic approach in the past, that the healthcare professionals would be in control, and the patient would either go along or not. The terms compliant and non-compliant have fallen out of favor mostly, I hope. So you can see the idea of patient access to their records is a recommendation to improve the quality of care in general, and leads to a very different type of relationship, more of a partnership with clinicians. Next, please. And this is now required according to law, according to the federal 21st Century Cures Act. The requirement of sharing components of the record has become, is a part of the law that has been implemented already. As you can see, there are some components that are still to be implemented. Next, please, Sandy. And this is what has to be shared with patients according to that law. And you can see on this list, this is really the meat of the medical record in a primary care practice. So I'll just pause for a minute. I suspect people read that. There are some exceptions, as there should be. Certain, Sandy.
Am I not helping you? There.
No, this is fine. You're always helping me.
Okay.
So you can see there's some exceptions. Some of those have to do with the nature of the interaction and the type of proceeding that might come from it, workers' compensation, things like that. There also can be exceptions that can be done on a system-by-system basis in defining exactly what access there is to children's notes. And those are things that you would have to look into locally. I'm going to turn it back to Sandy, though, to talk about how this applies to behavioral health.
Oh, goodness. There. I'm having trouble going back and forth between the camera and the advancing the slides, and my system takes any input as something to do one or the other, but I'm not doing well at controlling which. The clinical notes related to behavioral health are clear and for many folks a bit more difficult. That we are used to psychotherapy notes being excerpted, and in fact psychotherapy notes are excerpted, except that we have to be clear about how psychotherapy notes are defined. And in the law and in CMS has been defining it this way for some years, psychotherapy notes are not in the medical record. They are notes kept by a therapist in the drawer or some other place that do not ultimately go into the EMR. And if they're in the EMR, they are a part of the medical record. And so for us behavioral health people, we should be writing progress notes. And progress notes can cover everything that you need to put in a record, both for the benefit of the patient who's going to read it, as well as for the benefit of other clinical colleagues and regulators. There will be systems that will, and there are systems who are saying that certain notes are difficult for the patients. We're protecting the patients by not putting these notes in the EMR. There are other systems who are putting the same notes in the EMR, and it is part of the sharing. So the definition of psychiatry notes and so forth as being not accessible tends to be more cultural by site than be part of the law. And the law leans toward transparency. And this is what we all fear from transparency. And I've been there when this has happened. 20 years of my early career were spent in specialty mental health. And I was the one who had to get out the record when the patient came with all the signed papers that we put people through to give them access to their record. And commonly, they were not so much angry as dismayed that the therapist that they had been working with thought so little of them. It turns out that the language they would encounter, consider a mental status note, for example, was to them insulting. And so they felt that they hadn't really been as engaged, the therapist had not been as engaged with them as they had thought. Dr. Corson.
Thank you. So Sandy just talked about the fear of what will happen with the implementation of this law and the implementation of broad access to notes. And we were able to find in the literature a couple of studies that looked at what happened to people when they had access to their notes. And fortunately, at least these small studies suggested that our worst fears may not be justified. The first one I'm going to talk about happened not quite 10 years ago. It was one of those natural experiments that took place in 3 health systems in adult primary care settings. One, an academic medical center in Boston, a rural health system in Pennsylvania, and an FQHC system in the inner city in Seattle. The physicians had the opportunity to either choose to participate or not, and if they did, they committed to participating for a year. Patients would have access to their notes if their physician chose to participate. Nobody received any training in how their notes would be written. Physicians could think about and eliminate any patients from participation who they thought might be harmed by seeing those records. And there was a small percentage, 5%, about 1 in 20, were eliminated, and the majority of those had a serious mental illness, and that was the reason probably for excluding them. So you can see that there were differences if you look at the first 2 rows before implementation in who chose to participate and who declined. And you can see big differences in whether the physician expected the open notes to help patients and whether they were worried about the concerns that it would cause patients. And there were very different expectations of those 2 groups that probably led to whether they participated or not. You can also see for those who did participate that there were relatively small impacts either on the length of visits, the kinds of questions or the number of questions that patients were asking, and no participating physicians decided to stop after their 1-year commitment. They all stuck with it. Patients, you can see beforehand, patients who were also surveyed and were, it was the same cohort of patients surveyed that were either able to participate or not, depending on whether their physicians participated. So you can see the vast majority expected open notes to be helpful. Small percentage were worried that it would cause worry. And then you can see those who had the opportunity to participate, most took advantage and read a note. Though they reported that it increased their feeling of control. Adherence is our somewhat better word for compliance, and you can see people were more likely to stick with the treatment plan, agree with the treatment plan. You can see there were small percentages, but still significant, that had some concerns about privacy. On the other hand, a substantial minority shared the information with others, either family members or those who they turned to for health advice. Many wanted to be able to add information to their notes. And again, you can see with almost no exceptions, they would want to continue to have access. So this was popular and went well with the clinicians that participated and with the patients. And I love to quote my friend Sandy and point out that access to notes is particularly important for those who have a lot to deal with in terms of healthcare, because there's a lot going on. We're always rushed in the office. The ability to go back and review and remind themselves what was discussed in general is a positive thing. Next. And another study we found, this is a second study, looked at patients who were able to read their own notes. This is a different cohort in a different situation. How important did this group feel that this access was for understanding their health and healthcare, remembering, of course, that understanding is an important step towards engagement. So you can see for less advantaged patients, the vulnerable populations that many of us take care of, they rated the importance of access to notes even higher than those who they were being compared to. 3 times as likely somebody with lower education, twice as likely somebody from a minority group, and as if not more likely for people with poor health compared to good health. And you can see, again, people confirmed what we suspected, which is it's important to make notes available to people because it gives them information about their care. It helps them to understand what the clinician and the team's thought process is as they approach the patient's health issues. You can see that it gave people a better sense of the positive intent of the work of the healthcare team, which is very important. And it was able to be used, and Sandy will talk much more about this, it was able to be used as a way of engagement and achieving more equity with groups that often don't feel like they're well engaged with the healthcare system.
The behavioral health findings, behavioral health notes are more about, does the summary of the visit ring true to the patient? In as much as notes tended toward interpretations of the patient, in thoughts about what the patient really meant instead of what the patient said, those kinds of things, they tended to undermine trust. And in as much as there was a consistency in the behavioral health note between the patient's experience of the visit and the note, it tended to build trust. The other element that built trust was anything that made the note reflect the person of the patient, the individuality of the patient, as opposed to a male person with depression, and the strengths of the person. I learned to write notes like this during 20 years of seeing patients in primary care because I read back the note at any follow-up visit from the previous visit. And it started each session right where we were before. It let the patient confirm or disconfirm what I had in the note. I never was corrected about an interpretation in the note, though sometimes people would correct facts, like, I have 3 brothers, not 2 brothers, that kind of thing. But the starting out with the note as something that you're sure the person has heard made a great deal of difference in engagement, and in fact, often got me great points because the patient would say, "Oh, gee, I didn't remember it that clearly. You really listened to me." It was quite a relationship builder as a regular practice, and it didn't take much time at all. Neil.
Okay. One other important aspect, as our clinical notes will be shared with and read by the people we take care of, is to keep in mind some issues about health literacy, about literacy in general, which I was fortunate to be part of a project where I learned about this as a clinician 30 years ago. And I'm sure many of you are also familiar with this. It changed the way I talk to patients. It changed the kind of materials I would give out to patients when I realized this. So if you think about the fact that on average, people read at about a 7th grade level, I've also heard people talk about writing and giving information at a 5th or 6th grade level. So we're talking about, on average, people reading at about a middle school level. And when you add in issues of that are emotional, such as a health problem, that further reduces people's ability to understand the information that you're providing to them. And that's important. I had a conversation with a healthcare professional who had a question about something outside of their area of expertise. And even though this person in school understood some of the issues of statistics that I was explaining, because it was emotionally laden, I needed to remind this person of that. And so there's some general advice about how we communicate with patients in an understandable way. We'll go back to the previous slide, please, Sandy, just for a moment. There we go. That come out of health literacy, and then I'm going to talk about how they apply to the note writing and how you might think about these as you're writing notes that people will be reading. So simple language, short sentences, bullets are actually good to help people to capture the key points about what you're talking about. Avoiding jargon, or if you have to use it, make sure you explain it in plain language. Plain language is great. Avoid technical language when you can. And then teach back is a good tool. Again, many, if not all of you are familiar, so that you're asking the person to explain back what you said. That makes that's a good way to check that they understood it and they can repeat it back. So when you think about that with regard to notes, now I'm ready for the next slide. There's a few other pieces of advice. Some of this is repetitive. The point about, if you're going to put it in the note, you should have talked about it. That's really an issue of trust, and it very much reflects the kinds of things that Sandy was talking about in reading his notes back to his patients. We are very familiar with the language we use with each other, and it's important to remind ourselves that that language is a foreign language to most of the people we take care of. And there's some examples I'm going to show you in a moment. that will just demonstrate how our language that we use all the time from a sort of neutral scientific perspective can be emotionally laden and can push buttons for our patients. And if you think about how they might interpret that, it'll make sense to you. And then again, as Sandy pointed out, we know, especially our patients who struggle with multiple chronic illnesses and complex social situations, can have real challenges in achieving their goals, but we also know they work hard and that even small victories are important to emphasize. And so in our notes, we can identify those, especially knowing that our patients will read them, as an intervention to help keep them motivated, in the same way that we use motivational interviewing and other tools when we're having verbal interactions with our patients. So let's talk about just a few examples of how our language might be misinterpreted and how we might think differently about it. And again, think about, as professionals, we're using this terminology in a relatively neutral scientific way. A patient hears it as a way we're talking about our relationship with them and perhaps our opinion of them. And the word obese, we have a definition that's based on the body mass index, but it's heard as a judgment by the patient. Hopefully, we are not using SOB in a way that it's at all confusing for a patient, but it's always better to say shortness of breath or the patient has trouble breathing, which is a more understandable way. The issue of the patient denies is one that I hadn't thought about, but as soon as it was pointed out to me, it makes sense that we're simply saying that the patient does not have these symptoms, but in common terminology, denying something might mean you're lying. And we would not want our patients to misinterpret something in that way.
So,
Sandy?
yes.
Back to you.
So if we take it as a given that when we're writing something that seems neutral, that seems straightforward, and therefore that we're shortening our scientific descriptions so to have to write less, that will be taken as a relationship message by patients, how would we have to change just basic kinds of descriptions in order to reflect our knowledge that the person is going to think this is us writing about what we think about them? Well, from the start, people have names when you're writing in a relationship contact. You don't say the patient reports, you say Mary or Ms. Gonzalez told me. That their names and the descriptions of them are as we would say in a relationship. So he's not a 47-year-old male. John is a 47-year-old man or transgendered man. We'll describe him in the way he wants to be described, but we'll describe John, not any person of a certain gender. That the patient denied current alcohol use becomes John let me know that he no longer drinks alcohol. And so if we put this all together and make it the usual first few words of the note, we had to add a few, but not very many, to make it much more relational. MS, 47-year-old F with DM, obesity, and depression becomes Mary Smith is a 47-year-old woman who comes to the health center for help in managing her diabetes, her weight, and her depression. In fact, if we go a step more, we notice that, or we could notice that we tend to use words that are negative or passive in relation to people. The patient suffers from such and such illness. They are the receivers of both illnesses and treatments in most language, in the professional language we use. It doesn't take much to change those to more positive or active words, and you aren't changing the reality. Remember, we're always describing a reality. We're using different words that, in fact, will color maybe how we think about folks. So he doesn't suffer from diabetes. He struggles with diabetes. He's an active person. He's an agent in his own life, or he copes with diabetes. He refused to take. No, he decided against. If he refused to take, diminishes the person. They are more childlike. They decided against. That's a more adult action. Even though they decided something we don't recommend, adults have gone against our recommendations before. We can take it. Didn't keep the appointment, was unable to be here, was non-compliant with, had not seen the value of. Note how that changes the whole context. Is if he's non-compliant, we already did our job. We told him what he should do. He's just not doing it. And the implication is he clearly doesn't care about his health. Has not seen the value of. Now that's back on us, because we're the ones who know the value of it. It means we haven't conveyed it convincingly. We have more work to do. He arrived late? No. He was determined not to miss. Many people in his situation wouldn't have gone home, would not have come if they were running late, but he came late and made it. So in fact, that's something that we noticed his effort in this. Notes can provide a way of building partnership. So we build partnership by characterizing our patients as potential partners, as people who are interested in their health, even if they are not doing what we suggest they do, or that we highlight their past successes, even if currently they're not succeeding in the way we would hope for them. So Bob told me he thought vaccines were just designed to make money for drug companies. I'm impressed that he was willing to be honest about something that he knows I disagree with. While we have a ways to go before we're on the same page in this area, I believe productive relationships start with the kind of honesty that Bob offers me. Whenever anybody disagrees with you, you always have the option of saying that they were honest, because there are a lot of your patients who are nodding their head to get out of the visit, get it over with, who don't agree with you, but they don't tell you. And so the disagreeers have taken a step toward partnership, if you define it that way, and make it more likely that they will define it that way. Mary continues to work on her weight, though at this point her progress is slow. Her success with quitting smoking 10 years ago, after many years of trying, makes me suspect that her determination to improve her health will win out in the long run. We project success for the benefit of the patient without changing a prognosis. Another way is to focus on elements that you didn't say in the visit. I often put things in the notes that I was going to read to patients the next time that I hadn't said in the visit because I thought of it after they left, but I wished that they would hear it. So Mary seemed embarrassed that she'd not made more progress on her depression. She's still coping with fatigue, not enjoying her favorite activities. her weight and her A1C, which is still 8.5. She started walking more. I wanted to point out more clearly that increasing her exercise is an evidence-based approach to all three of these issues. And if she keeps up what she's doing, I suspect she may improve in the long run. If she reads that, it will be a bonding and a teaching moment. If she doesn't read it, it'll remind you something you might want to say next time. We use empowering language, and that means we study, if even when people have patterns of failure, we study briefly the exceptions to those patterns. We look at what worked for them because that's the skill base we'd like to start with. And or we notice the problems that didn't happen. So if, for instance, somebody's self-care is not doing well, or if they've lost their sobriety, often I found you can help people regain their sobriety by having them tell you how they got sober last time. And while they feel like a failure, you get to highlight the skills that they have that we need to be in touch with to help them get back on the wagon. Now, notice the problems that didn't happen, so that the drinks that weren't taken, the times when people in similar levels of stress wouldn't have gotten the degree of coping that the patient has gotten. And so patients almost always find it credible if you say, I know people with the kind of stresses that you face, and I have to tell you, many of them wouldn't be maintaining themselves as well as you are. Tell me how you're holding on, even if we're not making progress yet. Activating language. You want to attribute to people the ability and the commitment to make progress. And so you use words like he's determined to, she's committed to doing so-and-so. This person seems on a mission to improve her health. And express optimism. It turns out the evidence is very clear. The degree to which the professional expresses optimism for the treatment in relation, in a way that's believable to the patient, impacts the likelihood of success of the treatment. So if you were just looking for things that you could say to people that were attributions toward activation, here is an activation generator. Take one from column A, one from column B, and one from column C. Column A, you'll notice, is all tentative. If you're going to make attributions about people, you have to be tentative. You have no right to say for sure, but you can suggest something might be true in a way that they will think about it. So it kind of looks to me like you're learning to prevent health problems down the road. You know, I may be wrong, but I'm thinking you're getting more confident that you can follow through with treatments on your own. So we're looking then for a way to make our notes not only be not something that will drive people away, but in fact to be ways of engaging people in their care and in knowledge about their health, and of activating and empowering them. This is something that's been around for a long time, and now it's something that we would like to all find a way to take advantage of, since we're going to be required to have folks have access to their notes anyway. In the system in which I'm in, when I have seen my doctor, I get an email and I can click on that email and see my note. It is assertively made available to me, not something where I have to navigate a portal through 5 or 6 clicks. So thank you.
Sandy and Neil, that was incredible. I was mesmerized and motivated, and I see some other comments in the chat about how empowering this sounded to all of us, and looking at ways we can improve our practice in sharing our notes, but also in the content of the notes. I want to take a moment to thank our sponsors, and that includes, of course, HRSA, who funds this center, along with 5 other centers across the country in academic institutions, including Meharry, Harvard, University of Washington, Northwestern, and Mayo Clinic. I want to also thank the primary Center for Primary Care at Harvard, HRQ, the Academy, and of course, an institution for supporting this and this program. As a reminder, we run these webinar series. We try to do them monthly. Sandy leads this webinar series, so you're in for a treat for the next one, which is already in planning. And please join our community of practice. So we have a number of comments and questions, and one of the first comments that I wanted to pass to you is from Nisha, and this is a comment that Nisha wrote about. This is interesting. My initial reaction was, that is not a professional way I learned to write for healthcare. So Sandy and Neil, how do people pivot from the professional, the way that we tend to write, which is shorthand SOB, right, which means something totally different in common language, to begin to write in sort of this more person-centered approach, an endearing and empowering approach for open notes, or in the context of open notes?
I guess one thing I would say is, if you imagine you're speaking to the patient, it will be a lot easier. Imagining that you're writing only for medical colleagues and the patient might be able to sneak around the boundary of the barrier and see the note is much less likely to help you. If you think you're writing to your patient, I think things like using names and more engaging language will come naturally, but the kinds of empowering language we talked about right at the end, where it got sort of more complex and using the notes more as a clinical tool, I found that it helps to have the practice talk about it, to have the practice say, how would we, one of the things we do often is bring some notes that you would be embarrassed to have the patient read, and sit together and say, well, how could I say this in a way that's accurate, and what you find is a lot of what you think of as accurate is actually value laden. And if you think about the possibility there might be other values, the numbers stay the same, but what you make of it you might have some flexibility.
Great, thanks, Andy. Neil, I'm going to turn this question to you. This is from Bessie Duckett. This is familiar to all of us in primary care and clinical care in general. We rush for time. We want to make very short and succinct notes, which are not really friendly and doesn't really speak to what you two are presented. So the question is this: we know the EMR is a burnout point for healthcare providers or clinicians, and this may add to chatting time. Has this been studied? I think the question is twofold. How does this contribute to chatting time? You know, I will think about dot phrases and other things we can create, but has this been studied?
I am not aware that this has been studied. I can't say that I've looked into it exhaustively, though, and so I apologize if I'm not correct about that. You know, I think, as would be true in any transition, the transition to using the EMR slowed people down for a while because they had to think about how to use the new tool. So I think this is, I mean, the change has happened. Patients can read their notes. I think for all of us to think about, as Sandy pointed out, have we been saying things in ways that wouldn't be acceptable to our patients is something we have to think about. And saying it in ways that are simpler language. I think when we have technical things that we need to be clear about as we're communicating with each other, because notes do indeed have that role, that purpose of communicating amongst ourselves as professionals, we need to make sure that we say it in a way that the patient can understand what we're talking about. I've been working on shared decision-making for a long time. I think there's a lot of overlap in terms of how we thought about talking to patients about the somewhat complicated decisions that we wanted them to be participating in. And what we found is it doesn't take substantially more time to do that. And I think it will take more time as we learn, and as we get better at it, it will become the way we do things.
I like the way it was phrased. Think about you talking to a person and how would you state it in a way, but think about you also receiving information from someone else, and how would you like to receive that information from someone else? And think about you reading the notes. So there are other comments and questions here. And I think maybe to Sandy is, how do you see this approach being used in the context of a shared care plan? And I'm not sure, Nina, if you mean a shared care plan for the treatment of a patient with a team. Maybe that's a context perhaps, Sandy, you can try to answer it.
Sure. And people sometimes, when they mean shared care plan, when they say shared care plans, they mean a care plan that has both behavioral and medical elements. When I think of shared care, I think of a plan that has both behavioral, medical, and contributions from the patient. And as soon as you go to the plan that has contributions from the patient, it gets easy because you take care of that as in the structure of the plan. And there's a good deal been written on those kinds of plans. And in fact, we're going to talk about them in our next webinar. But the same rules or the same elements that you would put in that we talked about before, the behavioral health can be, it'll be more specific, it'll be functional in its definition of what would count as progress. It will have strengths in it as part of this is what we're building on, this is the foundation this person brings to the work, and that interpenetrates with the medical side. And the other piece is, for those who can do it and take the time to do it, it allows for a biopsychosocial take on the person's problems and issues. Their drinking seems to increase, and when it increases, their A1C is likely to go up. It seems that when they're drinking, it's because their depression has gotten more difficult. And so it makes the links for the patient as well as for each other in the definition of what you're trying to help the person with.
Right, and put it in their plain language, 7th grade, as you said, in a way that the patients can understand and accessible. I guess I have a personal question, maybe a thought, because the open notes is accessible electronically, and yet some parts of our communities, and as I pointed out, don't have access to electronic medical records because they don't have the equipment, the knowledge, or that means to use it. Does that mean we're leaving out a segment of our community, of our population in the move to open notes, and how do we address those challenges?
Yeah, what I've seen in this area is that yes, there are people for whom the difficulty is very hard to overcome without support from other elements of government or society, people who don't have the signal strength, even with their phones, to be able to participate in an internet-based interaction. For those, telemedicine and open notes become more difficult, and we have to face that that's what we have to do in connection with them. It would be easy to print them and send them if people wanted to do that. That would be available to anybody. But the other thing is that, for instance, imagine a practice that had a video on its website, and the video on the website told patients how to go through either connecting with telemedicine with their doctor using their phone, or reading their notes from the doctor with their phone. That sort of assertive outreach, we want to find a way to help you connect with us, is something that's valued by patients and that can be very helpful.
And I want to get through a couple more questions there, really some important questions. One by Dr. Williams. So he talks about, let me read it. Any thoughts on the challenge in putting into notes information that is useful, heads up for other providers, that the patient may have some challenges, right, that you need to be aware of, that may be less accepted by the patient. So you're trying to describe, you know, in the traditional way we think of patients that have been difficult. I think we need to get past that. But how do we communicate that to another provider to prepare them? Or would you suggest we use a different means outside the notes to do so?
Yeah. One of the things you do is acknowledge that the patient thinks differently. So when she came to me, she thought she had a deadly disease. I wasn't unable to find it, and that did not satisfy her. She was unhappy with the interaction with me, and I don't blame her, because I did not find what she was hoping I was able to find.
That is nice, Sandy. Masterly, masterly. And we'll have this recorded, so we'll be able to share it. This is really important pause for people. We have a minute or so for the next one more question, and I think that's important. Similar to Dr. Williams' question, how do you approach mental health status exams in open notes and other surveys? You know, these are kind of numerical things that we put in the charts, and yet we don't always explain what they mean in ways patients will understand well.
I have a history of mental status and with negotiating with insurance companies about it. I once had a discussion with Blue Cross Blue Shield in Massachusetts, and I said, I want to do mental status by elimination. If you don't hear about it, it was fine. And they said, well, I guess that's all right, but you have to list what you're eliminating. So we had a little list there printed, and we said all of the above is fine, unless it wasn't. And then, of course, if somebody looks like they're not doing well, that they're coming back from a hard night, we could say it that way. People understand that they came in not doing very well, showing the difficulty of their life when in the way they presented themselves. The other thing that I did in a different setting was to list the elements of what had to be there for the regulators as checkboxes, all within the note, and then have text in the middle. And so I would read the text. The patient could look at the checkbox if they wanted, but they mostly didn't pay much attention to the checkbox. They just read the text that was in the middle that I read back to them in those days.
Well, thank you both to Dr. Blount and Dr. Corson. I also want to thank Gina and her crew for putting this show together. This is impressive and really informative. Look forward to next month's webinar. And again, we invite you to attend with us. Again, I want to thank some of our sponsors, including the Harvard Center for Primary Care, HRQ, and the Academy for co-sponsoring this webinar. We hope you join us again in our community of practice. Thank you. And happy holidays.
Same to everybody. Thank you.